Good evening, everyone. We are really happy to have this new European Society of Contraception webinar where we are going to have the new insights for prescribing oral contraception to first-time users. I am Manuela Farris. I'm the Vice President of European Society of Contraception, and I'm really pleased to have you all here for this new one. Some practicalities before starting the webinar. You can activate the question and answer clicking on the question and answer button. You can upvote each other's question with a click on the thumbs up sign, and a selection of questions will be addressed after both lectures. The European Society of Contraception aims is to leading professional society working collaboratively in Europe and behind to champion evidence-based education and research in sexual and reproductive health and rights, including facilitating people's informed decision in choosing and using contraception. You can apply for a membership, which is going to be 100 euros for 2 years, 7 euros for each year. You can apply on the European Society website. You can see the link here. And if you apply as a member, you are going to have very nice benefits like the access to European Journal of Contraception and Reproductive Care online. You have regular newsletter and free access to all the webinars and reducing the Congress events registration fees. We also have affiliation with European organization, and in this case, if the organization have more than 10 members can qualify for a discounted fee of 40 euros per member. And I'm really pleased to invite you all for our next Congress, which is going to be held in Belgrade, Serbia, from the 6th to the 9th of May. You can find the registration on the website, and you also will find all the topics for abstract. Abstract submission deadline is 31st of December 2025. This is a recorded webinar, and we are going to hear from Terhi, Piltonen, Finland, emotional health in first-time user contraceptive. We will have Professor Rossella Nappi from Italy, which will talk us about drospirenone and sexual health in starters. We have the bleeding outcomes with mutual Creinin. We have a multi-level evidence of lower VTE risk with natural estrogens with Professor Jonathan Douxfils. And then we have the association in adolescents with Angelica, Lindén, Hirschberg from Sweden. We will have then the question and answer session, which will start at 4:10 p.m. with all the panelists will be online with us in order to answer all your questions. I hope you will enjoy the webinar, and we'll see each other later on.
Good afternoon, everybody. I'm happy to see you, and it's easy to talk in a session where you have all this bag of food in front of you. So very, very good position here. Okay, so let's talk about mood, as we know that that's quite important when we are seeing our patients. And indeed, many of our patients, they are considerate that they want to have a certain kind of a contraception or contraceptive to be used. And of course, what we want is efficacy. But currently, I think there are very, very good preparations in the market. So it's not a question about anymore about efficacy. They are very efficient. But now what we really want to do is look at the bigger picture and try to figure out how otherwise we would be able to benefit the women by prescribing these preparations. And menstrual problem relief is very important aspect when we are choosing the contraceptive method. And this is by the fact that about 80% of the women, they experience physical changes related to menses. And on the other hand, 20 to 40% of the women, they experience menstrual cycle related symptoms. And on the other hand, my patients, they often say they are very concerned about the mood changes, what they're going to experience after starting the pill. And it is true that mood changes may occur with the hormonal contraceptive use. But on the other hand, I think we also can think about that these preparations might also offer a solution. And that's why we have been carrying out a quite large trial. This is a phase 3 trial that was carried out in Europe and Russia, and with the E4 drospirenone for 13 cycles. There were altogether about 1,500 participants, and I'm going to concentrate on the starters, which are about 530 women. And to many cases, we see that it's the young women also that are very concerned about the mood. So here, about 50% of these women were less than 25 years, and about 70% were normal weight. What we evaluated were 2 time points during the menstrual cycle, so premenstrual symptoms and menstrual symptoms, and the tool that we used was menstrual distress questionnaire. And this questionnaire, it has other domains, but these were the ones that we published, so 4 different domains. And today, when we are talking about mood, we are going to concentrate on these negative effect outcomes. So simply, this is the result. So you'll see that there was beneficial effect on the mood for the starters. So the negative effect symptoms, they improved while the women were on this E4 drospirenone preparation for 13 cycles. And the improvement were seen both in premenstrual and menstrual phases. So that was very good that both of these time points when they can, where the symptoms can occur, quite often they were improved. And the most bothersome negative effect symptoms were targeting these 2 symptoms, mood swings and irritability, because over 10% of the women experienced both of these symptoms. So they were the ones that also got relieved after the intervention. If we look at more closely the results and we look into shift analysis, and here it's a little bit busy slide I'm going to talk you through. So there are 4 different groups here. So you see that there are the ones that do not have any symptoms at baseline, mild, moderate, severe, and then how the improvement was, or how was the changes occurring. You'll see that most of the starters actually experience milder mood symptoms, and many of them remain also asymptomatic after following this treatment. And you'll see that the ones who really benefited the preparation was the one who had moderate to severe symptoms at baseline. So this is a very good news for the women who are afraid that their symptoms are going to get worse. So you'll see that this was very, very good result as for the mental distress outcomes. And this was also underlined by the fact that in this study, it was actually less than 1% of the women that discontinued because of the mood changes. So that's also quite important. So altogether, if we are looking at this data and altogether our clinical expertise, I think we can all gather that bothersome symptoms related to menstrual cycles, they are very common, and women are concerned that they will get worse when they are on these preparations. But here we are able to see that the starters for E4 drospirenone, they improved with their symptoms related to negative effect. And in the shift analysis, if you remember that picture in your what I showed earlier, was that the starters reported improvement in mood, or they remained symptom-free during this preparation. So I think this is a very good message for the women, and I think these mood changes should take into consideration, and they should be actively asked when we are prescribing these medications. But thank you.
Terhi, you mentioned some of the other menstrual distress question symptoms. Were similar changes seen in those other parameters, like negative as you described for negative affect?
Yes. Now, yep. So yes, for these different domains that were there, we also, for example, pain was also assessed, and there was also a similar kind of a change, improvement in pain perception during when the women were on this preparation. So the very typical symptoms like back pain and cramping, they got also relieved during the 13 cycles.
And then, we know that study participants sometimes aren't the same as the people that we see in the office. What has been your clinical experience, both from the study and then even after? Are you seeing similar types of outcomes?
Yes, well, we participated in this study with our team, and we were the biggest ones to recruit from Finland. And I think many of the women were very concerned about this pill. They were actually quite sad not to be able to continue with it because it was not on the market at the time. But I think I've been able to see the same things. I treat lots of young women as well. So I think the mood changes. I think that's one of the things why people are very, very happy about this pill. I think I can see now replicating the same outcomes what we got when we were on the study now in my clinic. So yes, I think I can see that this is really also in the field, even though it's not a clinical trial in my office.
Right. It's interesting because I couldn't participate in the clinical trial because I was overseeing it, but the patients I put on it similarly,
Yeah.
they do feel different, and it's kind of almost hard to believe, but it's real.
Yeah.
And what about this information is interesting, but it doesn't necessarily drive guidelines. It's not usually guidelines usually are mentioning other things. Do you have any thoughts? Or are there any new guideline issues?
I think it's a very timely question. So in Finland, we, after a 10-year pause, we now really updated our Finnish guideline. And we wanted to now include these natural containing estrogen pills also in our national guidelines. So I think that we are now the first one that is really recommending taking a stand that if you have mood symptoms, this is something that you should try to switch or start with this preparation. So we try to make very practical advice for the clinicians to use on this guideline. And this is one of the ones that we made.
I like that idea. I don't know if any of the rest of you too, but the importance there too is if people start with something and have a good experience. I mean, we've all seen patients, you all have too, that say, "Oh, I can't take pills. I don't do well with them." And that's their first experience. Sometimes can have that impact. All right. Well, we were talking a lot about emotional health, and I think we're gonna. We all know that physical and emotional health really, when we are talking about sexually active patients, that we are interested as well in sexual health. So Rossella is going to talk a little bit about sexual health outcomes.
Thank you. Thank you, Mitch. Yes, indeed, we will discuss estrogen and sexual health in this starter women. And you see that we really need contraception for many different reasons, but you will agree with me that we need for sex. And most adolescents are sexually active by the age of 20. You see here, this is a cartoon that includes young people between 20 and 24 from Finland, Sweden, France, Canada, UK, and the US. And more or less, more than 80%, they are already active. Why so important to address the issue of sexual health? Because some studies out there clearly shown that when you have a better sexual health, this means you have also better physical health, better mental and emotional health, and better social health. You have also more possibility to be positive, for example, in terms of prevention, primary prevention, and you feel much better in your social environment and with your partner. And we have really to consider the topic of adolescent sexuality with a biopsychosocial approach, considering that we have some biological determinants of sexuality, but there are so many other aspects we have to consider if we really want to address this topic properly. This is the reason why some years ago I published with one of my residents this editorial I entitled 50 Shades of Sex. Why is this? Because there is absolutely no doubt that hormonal contraception, to me, a girl that I was born in the 60s, the pill is a liberation for sexuality. But every day in our office, you will agree with me, we face the challenge of these women reporting side effects in terms of mood and in terms of sex. But when we look at the studies out there and we do these systematic reviews and analysis, we see a lot of inconsistency in the data out there, depending on the pill you use, the route of administration, and we have only few well-conducted studies. Angelica did one of that, in which we see very clearly that that can be an impact on mood and sex of the pill, but this is really very individual response of the woman. There are some women that can be vulnerable to the challenge because hormonal contraception can behave as an endocrine disruptor. And why is this the case? Because it's biologically plausible that when we shut down the ovulation, we remove the estradiol and even the pre-ovulatory androgen peak. We reduce overall the androgenic and the estrogenic milieu within the tissue, directly in the tissue. Why? One of the reasons can be we increase the sex hormone binding globulin, we may affect the receptor, we may affect enzyme activity, and so on. And at the end of the day, some women may react, developing some kind of symptoms, low libido, poor arousal, low lubrication, sexual pain, and so on. What about estetrol and drospirenone? I would like to share this manuscript that was published by a good friend of mine in Italy, Salvo Caruso, and what he showed. He did a study in which he included a cohort of more than 300 women between 18 and a wide range of age, not only adolescent, but what he found that when you use natural estrogen in general, so estradiol valerate, estradiol, and even estetrol, you really have a positive impact on the free androgen index. Why? Because you increase less sex hormone binding globulin. And this may translate in a better, let's say better, index of the female sexual function. You know, this is the most validated instruments we use in clinical practice. And you see here domain of lubrication, orgasm, and satisfaction. And when we compare EE containing pill and estradiol and estetrol containing pill, these scores are quite better. So we can say that with these compounds, we respect the sexual function of the individual woman. And to have this in our hands is important. Why? Because we have really to fight this concept of hormonophobia. And when we think about hormonophobia and pill fatigue, women, they are feeling so, this fatigue to take the pill, to develop side effects, this is something we really need to address in our consultation. And it's very important to improve the narrative that is out there in the social media. We have to acknowledge that some side effects may happen, and we really need to avoid to dismiss or minimize side effects, because we have seen that if we avoid, women, they believe they cannot trust us because we do not acknowledge they can have a problem. So at the end of the day, we really need to provide a balanced conversation to facilitate informed choice and to promote what I would like to name reliable, cost-effective health literacy, because this is the key for communicating to adolescents. And I would like to finish with the word of another friend, Johannes Bitzer, because Johannes, together with a group of people working in adolescent health, synthesize very well the key message for me of this short talk. Tailoring counseling approach to address full the biological and psychosocial need of women. And we really need to consider sexual and reproductive health together in adolescents, because this is very important to empower them. We really need to explore the feeling and expectation around contraception of young women, and we really need to put them at the center of our consultation in order to help them to take their own decision, because this is empowerment. Thanks a lot for your attention.
So Rossella, thank you so much. Rossella, and I appreciate that you focused on the natural estrogens, the various pills that are available. And I think it links a lot, Terhi, to what you said about women and their first experience with a pill. If you have a negative outcome, whether it be mood or whether it be a poor sexual outcome, that it taints them for years to come. And we're going to learn a lot more about the use of natural estrogens in adolescents later in the program. You have a poster later in the course of the program, and I don't want people, I think people should still come hear the full presentation, but do you want to give us a little bit of information because it relates to this presentation?
It's not a poster.
I'm sorry,
it's an oral communication, and I don't want to screw up the surprise. Yeah. But what we but what we will show, we really will show some data of a proper study conducted in which we clearly shown that the positive effect that we may have by using estradiol pill in terms of sexuality, mood, and well-being. And when I say positive, I don't want to say better. I just say that we respect very well the female body, because you have to think about the natural estrogen. They are much more similar to really what is happening at the level of the receptor when we have our own estradiol. And you have to consider also that when we use, for example, drospirenone, it's true that drospirenone is an anti-androgenic progestogen, if you think about the 50 shades of sex. But you know as well that it gives you some benefits, for example, in terms of feeling water retention, and you improve also acne, and you have other effect that they are positive for sexuality. So we have always to think about not just the hormone, but really the biopsychosocial approach. And if you are taking a pill that make you feel good physically and mentally, this will help a lot your sexuality, and this is very important to me.
You know, Rossella, you brought up the anti-androgenic effects of drospirenone, and I think that's important. People don't realize necessarily, or you may have learned this sometime in your schooling and forget that we are replacing natural progesterone, and progesterone has anti-estrogenic, anti-mineralocorticoid, and anti-androgenic actions. And the only progestin that we can prescribe as providers that mimics the same effects of progesterone is drospirenone. Every other progestin we use lacks all of the same actions of progesterone. We're depriving women of what they normally would be seeing throughout the month. So I appreciate you bringing that up. How do you work this into your counseling when you're seeing patients?
Yes, this is a very nice question. You know, I always include the discussion of mood and sexual side effects. And I simply say, listen, there are a minority of women when they take a pill, especially for the first time, because it's a big change in your life, and they report having some kind of sexual side effects. And if this is happening, please let me know in 3-4 months. I always ask to my patient to take a little bit of a diary. Now women, they do it with their app. And I say, put on the right the good things, on the left the bad things. And we will try to discuss that. Don't be afraid to report some problem you may face in taking hormones. It's absolutely normal to change the pill. Maybe the first shot is not good. And I try to figure out which is the best pill for you, but sometimes this is not an easy task. And women, they really appreciate it because they believe there is another possibility. Whereas if we overstate so much, if we overpromise too much to our patient, then we will fail because they will come back and they will say, okay, if this was the best one for me and didn't work, I will not take another one, and we lose the patient in terms of contraceptive adherence and other extra contraceptive benefits. And with this, I think we have really to move to the next part, and it's my pleasure to invite Mitch to discuss a very important point for compliance, that is bleeding control, because women, they care very much, especially adolescents. Please.
Thank you. Thank you, Rossella. Actually, I'm glad we have this because I like to walk when I talk. So anyway, as we've already learned, menses can be unpleasant. We see a lot of patients who have complaints that occur primarily during their menstrual cycle. You've seen some of the data already. This is a recently published survey from 6 European countries that looked at almost 3,000 women of reproductive age from Europe. About half were using a hormonal contraceptive and half were not. And of interest, about 71% of people who were using hormonal contraception also stated they used it for non-contraceptive benefits. And this is remarkable because older studies said about 40% were using it for non-contraceptive benefits. So it shows more and more users appreciate this part of using hormonal contraception. And the most common reason, over 40% said menstrual irregularities, about 32% for premenstrual symptoms or syndrome, and about 25%, a quarter, for heavy menstrual bleeding. So our patients have these issues and they know that hormones can help them. And it's important for us, as we've already discussed, to talk about these issues. These symptoms affect activity. And I like this study out of Australia from a few years ago that looked at about 880 women who were non-athletes, because we know that sometimes athletes will use hormones to adjust their menstrual cycles related to their athletic competitions. So these were non-athlete participants, about half hormonal contraceptive users, about half not. And the majority of the hormonal contraceptive users were using oral contraceptives. 90% of them said they experienced menstrual complaints of some sort, and that they used their pill very commonly to avoid their withdrawal bleed at least once in the last year. And this is something we don't think about, but 3/4 of patients in this survey said at least once in the last year, I had something going on that I needed to avoid a withdrawal bleed because I needed to avoid the menstrual symptoms I was experiencing, or a lower percentage for engaging in physical activity, or just for convenience. But the most common reason is those menstrual symptoms. So as we've talked about throughout the process here, this is real. And we know that, as you can see from that data, just from the fact that people use it, that hormonal contraceptive users have less premenstrual and menstrual symptoms. So in this survey from 12 European countries, about half hormonal, half non-hormonal contraceptive users, the symptomatology for virtually every menstrual-related symptom was less among active hormone users, other than headache, was less than it for women that were using some type of combined hormonal contraceptives. So I think we get the message from our patients, from these surveys, from their real life utilization. I'm going to focus a little on bleeding because women are using these products for their symptoms in addition to contraception. And bleeding is another area where we can potentially, I'll use Rossella's term, lose our patient if we aren't thinking about what the effects are going to be on their cycle for bleeding. And it's important for us to remember that regardless of the formulation, in the first few cycles is when the most unscheduled bleeding occurs, and we need to prep our patients, helping them understand that this will improve with time, because we don't want people to start using a product and then say, oh, this isn't for me, this doesn't work for me. Remember, they're also getting used to taking a pill or changing their ring or changing their patch, whatever it may be, and that poor compliance results in more unscheduled bleeding. So prepping the patient is important. Now, this is the data from estetrol-drospirenone, and this is a slide that the people in the back, you have the best seats, all right? Because this is one of those global view slides, and you can take away so much from this, where blue is spotting, red is bleeding, all right? And what can you see really easily in graphic form? That women using this product have regular withdrawal bleeds, that there's a little more unscheduled bleeding in the first few cycles, and it gets less with time. And importantly, the majority of unscheduled flow that occurs even within that first cycle is spotting. And in this study, spotting was defined as no use of any menstrual products, not even a panty liner. So the majority of unscheduled flow that occurs with estetrol-drospirenone, which declines over time and gets less and less, is spotting that doesn't require sanitary protection. And when you look at the results from the phase 3 trial, you can see here it shows that the majority of people that are having unscheduled bleeding are having spotting, that bleeding occurs in less than 1.5% of people in each cycle, unscheduled bleeding, and that over 90% have their scheduled bleed. So you saw this in graphic form really easily. These are the numbers, and this excellent bleeding profile resulted in a very low rate of discontinuation across the study for bleeding complaints of 2.5%, which is incredibly low for a combined hormonal contraceptive study. Right? So you could see how this all translates to an excellent bleeding profile. So how does this compare to other products? And I think this is important for us to understand. There's this really great publication from my friend Dave Archer and Diana Mansour and Jean-Michel Fouadart, where they looked at all of the phase 3 data that was submitted to regulatory agencies throughout the world and the scientific publications that went along with those submissions, and said, what is the phase 3 data for a lot of the products that we prescribe? So I want you to look at the slide. Don't read the words. I want you to look at the colors. All right. If you're taking pictures, you'll get the words. But look at the colors, because the first thing to take away from this study was as they looked at different products, and we're going to focus on these 4 products, you can see the way that spotting is defined, the way that bleeding is defined, and the way that scheduled bleeding defined is all different. That's the different colors. So each product used different definitions. What that means is they're pretty close. But what it means is we can't look at 1 or 2 percentage points difference and say, aha, this is better or worse. What we're looking at is general patterns, right? Do people get generally the kind of bleed that they would expect using this product? It also underscores, and I give talks all over the world about the fact that we need bleeding guidelines, and there now are bleeding guidelines that I've published with some of my cohorts, and there's a new one that just came out from FHI 360 from a worldwide collaborative saying we need to use the same reporting guidelines, because this is about people just making stuff up, all right? But the bottom line is we can get a general idea of what the bleeding is. We can't compare 1 or 2 percentage points differences. And this is the data. So let's look here at the top. This is E4-drospirenone that we just talked about in that graphic presentation. You can see the majority of people get withdrawal bleeds, that there's low rates of unscheduled bleeding, and that goes down over time. And we know the vast majority of that flow is spotting, and very low rates of lack of a withdrawal bleed. You can look up here at ethinyl estradiol drospirenone. This is Yaz, all right? You get a very similar profile. So here we have a natural estrogen that has pretty much the same bleeding profile in a phase 3 approval study as an ethinyl estradiol drospirenone product with regular withdrawal bleeds, very low rates of unscheduled bleeding, and very low rates of lack of a withdrawal bleed, all right? And we go down here to another natural estrogen. This is Clara, all right, with estradiol valerate and dianogest. And you can see that you still get regular withdrawal bleeds, but definitely at a lower rate, at about 80%, all right? You get about the same rate of unscheduled bleeding, although it doesn't decline as much, and a higher rate of lack of a withdrawal bleed. Now, the lack of a withdrawal bleed doesn't mean they have amenorrhea the whole time, because they may be getting unscheduled bleeding and just not their withdrawal bleed. But they're not getting as much predictable bleeding as you saw in that really nice graph as you do with estetrol-drospirenone. And then lastly, let's take away the estrogen and look at drospirenone only. All right, you see very low rates of scheduled bleeding, very high rates of absence of scheduled bleeding, but why, although it's absent, what are they getting? Unscheduled bleeding, all right? So when you take away the estrogen, you get high rates of unscheduled bleeding, right? And you don't necessarily get no bleeding. And you can see this by these other numbers here. Look at these small numbers here. These are actually really important. These are the number of people in each cycle. And what you can see for these studies, there were relatively few discontinuations throughout a 1-year study. And here with same thing with Yaz, same thing with even the estradiol pill. But when you take away the estrogen, you start with 2,200 people, you're down to 700 by the end, because there's very high rates of discontinuation. Right. So one of my colleagues says, well, it's really nice if they can get to lack of bleeding if they can last that long. All right. And that's the problem of removing the estrogen. Right. You have very poor bleeding profile. So it's important for us to set realistic expectations for our patients, regardless of the combined hormonal contraceptive formulation you're using. Use formulations with predictable bleeding, and menstrual improvements are an important part of the non-contraceptive benefits that we describe to our patients who are using combined oral contraceptives. Thank you.
Thank you, Mitch. Very important piece of information. And if I may ask you, usually we say, okay, the first 3-4 months and then you adjust. But imagine that the woman report you unexpected bleeding following, let's say, 6 months, 9 months. How you solve the issue? Which one are your tips and tricks to try to help the woman to put into perspective?
Right. Well, a couple of things. First is that we have to remember too, all of this data is for phase 3 studies comes from not the patient you're describing, right? People who enter studies have regular cycles, have no bleeding problems. So we don't really have good data on what pill is the best for helping people who have bleeding problems. And it's important for us to think about, are there other issues we're missing first, right? It's easy to say, here, just try this pill, just try this one, leave me alone, get out of my office, right? It's easy. But you have to think about things like chlamydia infection is much more common in people that are having bleeding problems than in people who are not having bleeding problems. Is the pill a good option for her? Is she really remembering her pill daily? And maybe a non-daily option is a better option for her. If she really is taking, if she says, look, I'm doing what I'm supposed to be doing, then it's really a matter of looking at the pill that she's on. If it's a lower estrogen ethinyl estradiol pill, you can go up to a different estrogen. You can change the estrogen, change the type of progestin. Might be, usually it's the balance between the estrogen and progestin. That's a whole other talk on what really the progestins are, but changing truly the family of progestin from a pregnane to a gonane to a spirolactone, whatever it may be, a 19-norprogestin. But those patients are the harder ones. But keep in mind, none of the data that we have for any of these pills addresses those exact patients.
Yeah, interesting. And do you believe that characteristics of estradiol may do some difference in the control of the endometrium in comparison to estradiol, thinking about the good cycle control expected and a low rate of amenorrhea and spotting?
I don't know what the impact of estrone is. I think it's conceptually, people have conceived of things, but we don't have any, I don't think there's good data on that, because that would come from estradiol conversion, whereas estetrol doesn't make any, and ethinoestradiol maybe a little. But I don't think we know. I think the hardest thing is, I think the most important thing is something that you both said earlier, which is to tell the patient that, this is about you. I'm here for you. If you have problems, there's lots of different formulations. Come back and talk to me.
Fantastic. Yeah, we still have to study, I think. This is a relatively new estrogen. And this is the reason why now we move forward. We have focused our attention on mood, sexual well-being, cycle control. But now this is the subject that is really very, very important when we prescribe a pill to a young lady, that is safety. Please, Jonathan, address the impact on VTE, please.
Thank you very much for this very kind introduction. And I'm always impressed about the data on the bleeding pattern and the role of the estrogen. And we really see that we know that the estrogen has been a concern, especially when we are discussing about the safety of the combined oral contraceptive. And here, switching from synthetic estrogen to natural estrogen can really be a solution, I think, in order to mitigate the risk. So When we are speaking about the risk of VTE with combined oral contraceptive, I think it's interesting to know that since many years, in fact, we are collecting data from different different level of evidence. And especially here, I will focus my talk on 4 different parts. So I will start with modeling data, biological data, because you know, when you are discussing also with the regulators, sometimes they are claiming, okay, we don't have a causality link with what you are claiming, but I think it's always interesting to go to the basic and to understand how the estrogen can affect the hemostasis, and then this can be translated into an expected relative risk of VTE. Another point is that since many years and since more than decades, the European Medicine Agency requests that manufacturers of pills conduct post-authorization safety studies, and especially since the referral in 2013, they requested 2 important paths with natural estrogens, so the PROE2 and the INASCO, and we will discuss this data because I think that now that we have this data in our hands, we need to take action. From that, I will present you some very interesting meta-analysis data and also the extraction of the risk that we can have from pharmacovigilance database. Maybe some of you are quite familiar with this, but we know that the risk of VTE is associated with a resistance towards activated protein C. And at the end, combined oral contraceptive may really stress out an additional risk by putting the lady at an increased resistance toward activated protein C. And this is translated here by the NAP-CSR. So interestingly, what we can see is that when you increase the dose of ethinyl estradiol, you can see, for example, here from ethinyl estradiol 20 to 30, you can see that you have a higher NAP-CSR. And it's quite interesting because the higher the NAP-CSR, the higher the expected risk of VTE we can have from this model. So this was a model based on a surrogate marker of the VTE risk. And interestingly, then we just check, okay, the model is able to estimate a risk, and how does it translate compared to the risk that has been reported in the literature, and we have a perfect match. So this is really interesting. It means that when you are considering the risk of VTE, it is really reflected by the increased resistance towards activated protein C. And these were data that are available in the literature since more than 5 years. So moving from that, we can check, okay, observational studies, the PROE2 and the INASCO studies with natural estrogen, Zoe, Clara. What we can see from these studies is that you have a lower risk of VTE with E2 Dianoges compared to ethinyl estradiol containing pill. So switching from synthetic to natural estrogen reduce the risk of VTE. And the last updates from the PROE2 from the INASCO study really tell us that even compared to ethinyl estradiol levonorgestrel, E2 Dianoges is safest. We have the same trend for E2 NOMAC. The fact is that it's not statistically significant, but you can see that the point estimate is very close to the one that we have obtained with E2 Dianogest. The fact that it's not statistically significant is just because the regulatory just asked to make a non-inferiority trial. It means that if you are asking a non-inferiority trial, then the objective is just to demonstrate that you are not inferior. So this is what they were able to demonstrate, but the point estimate, the effect size, is already very interesting because this is totally in line with a reduction of the risk if you increase more lady in this study. So 1 year ago, I decided with my team to do a systematic review of the literature and a meta-analysis of all the data that we have that can compare natural versus synthetic estrogen. And the results are very clear. The results are very clear. Whatever the study, we have a very low heterogeneity, 0%. We demonstrate a 33% reduction in the risk of VTE switching from synthetic to natural estrogen. And it is important, maybe for some of you, you are not very familiar with that, but this is a crude estimate. It means that we did not make any adjustments for confounding factors. And we know that natural estrogen are often prescribed to ladies with more confounding factors, with more risk factor for the risk of for VTE, compared to those who are prescribed with ethinyl estradiol containing pill. If you go into much more details into this, this meta-analysis, you can see that when comparing directly natural estrogen versus 18-estradiol levonorgestrel, we even have a reduction of 50% of the risk. It means that this is consistent with observational study. It's logical. It's a meta-analysis of observational studies. But even for those who were not asked by the European Medicine Agency, these registries also tell us the same story. Switching from 18-estradiol to natural estrogen reduce the risk of VTE. And then it led me to a final analysis, which is an analysis of the pharmacovigilance database. And we extracted all the adverse events with combined oral contraceptive in the European Medicine Agency database. And interestingly, what we were able to demonstrate is that the reporting ratio, so the rate of adverse events that are speaking about thrombotic events, is clearly lower with E4 DRSP and even E2 pills compared to 18-estradiol containing pills. And even compared to the safest or considered the safest, EELNG, we can see that we have a huge reduction in the reporting ratio of thrombotic events. It means that based on these data, we can claim that we have less report of thrombotic events in this ultravigilance database compared we have less report of thrombotic event compared to 18-estradiol containing pill. And I think it's an important message because you can see here that on the left, we are speaking about natural estrogen, and on the right, we have 18-estradiol with different progestin. It's clear, EELNG in a world in which you only have 18-estradiol is probably the safest, but now we have also the natural estrogen, which are clearly game changers. So this slide is also important because it's a summary of all the data that we have still several decades. Whatever you are looking at biological investigation, switching from EELNG and synthetic estrogen to natural estrogen is considered safest. It's safer because you have less impact on the hemostatic system, you have less impact on the liver with natural estrogen. When we are looking at observational studies, it's the same. You can see that switching from 18-estradiol to natural estrogen also reduces the risk. And if you are also looking at the data from pharmacovigilance database, and I will invite you to see my presentation on Saturday discussing also the results from the FIRS database, you can see here that you have less thrombotic adverse event reported with natural estrogen compared to 18-estradiol containing pill. So it's really important because whatever the level of evidence that you want to assess, it strongly supports the safety of natural estrogen compared to 18-estradiol containing pills. And both the findings from randomized controlled trial, epidemiological studies, meta-analysis, biomarkers consistently confirm that E4 DRSP has a good hemostatic profile and is safer than 18-estradiol containing pill. I thank you for your attention, and I'm open for the discussion.
Thank you, Jonathan. Very, very clear. And, you know, my only thinking here is that we still don't have a pass study with estradiol and drospirenone. But do you believe that with estradiol you really make drospirenone safer if we think about that this is a progestogen that was a little bit under the microscope in terms of thromboembolic risk?
I think that when we are speaking about the risk of VTE, the thing is that the risk is brought by the estrogenic component, and at the end, the thing is that with estradiol we can definitely use drospirenone in a safe way. This is totally different compared to 18-estradiol containing pill. In fact, with EE drospirenone, you have an increased risk of VTE due to 18-estradiol, which is not counterbalanced by drospirenone. But here, you don't have a risk with E4. So as you don't have a risk with E4, you can use drospirenone without any problem. And this is exactly what we have observed in the pharmacovigilance database. So in my view, up to now, obviously the European Medicine Agency, and it is a class label, they request a post-authorization safety study. It's something that is, I would say, regulatory administrative task. But what we have here, clinical data coming from biomarker studies, observational studies, pharmacovigilance database, all the results are consistent with a lower risk of VTE with natural estrogen. And I'm not sure that it will change the game waiting for 7 or 10 years to get the result from a post-authorization safety study. And to be honest, I think that with all the data that we have here, now it's clearly an ethical issue not to change the guideline. Because we have clearly a difference between natural estrogen and synthetic estrogen. And in my opinion, and it's really, really interesting to look at the data in another way. If since the 60s, natural estrogen have been on the market, I think that today 18 estradiol will not be approved.
Yeah, this is really something we have to think about. However, I have a little concern, cost.
Yeah.
Because, you know, it seems that if we prescribe EE level that costs nothing, we are not doing a very good job. And when we consider the cost, I would like to have your comments.
Yeah. It's quite interesting because here, if we are speaking about the risk and the number of thrombotic events associated with the pill at the European level, you have approximately 23,000 cases of VTE each year, which are due to combined oral contraceptive containing ethinyl estradiol. It's really, really important. The cost, the societal cost of a VTE, it's not only taking an anticoagulant drug. There is also loss of productivity and all these things. Each year, it can cost more than 100,000 euros. So considering 23,000 cases of VTE each year, 100,000 euros in a young population, the societal cost is really, really impressive. And at the end, it costs more than 2.5 billion to take care of these VTE events. And if we are able to reduce the number of VTE events by 50%, as it is the case with natural estrogen, then we can save money. And this money can be reinvested to provide access to natural estrogen at the end. And everyone will be happy.
So governments should give money to Gideon, to Bayer, to Teramax, to save.
No, but I think that if you have a very attractive product, and if this product is cost effective, and we really need to do this cost effectiveness analysis, because the data that we have in our hands are really, really clear cut. It's crystal clear. So you have the cost of a VTE, which is very important. The number of cases of VTE is important. And at the end, you can save money by just changing the way you prescribe the pill today, by being safer than with estradiol containing pills.
So Jonathan, on one of your slides, you were talking about the pharmacovigilance data, and you also were able to extract some of the drospirenone data on that ratio. I think you moved over that.
Yeah, for drospirenone, it's exactly the same as with E4 DRSP. So we have a reporting ratio of approximately 7%. So it means that there is no difference between E4 DRSP and DRSP alone. And I think it's also a very good message to mention that here the risk is not driven by the progestin, and that natural estrogen, especially estetrol, is not having a risk on top of drospirenone.
Okay, thank you so much. Hopefully you're putting more questions for Jonathan. So we've talked about the importance of safety for starters, especially the youngest adolescents. And I'd like to introduce Professor Hirschberg, who is going to talk about brand new data for all of you on the use of drospirenone in adolescents.
Thank you very much. So now I present you completely new data, and it's the results of a phase 3 clinical trial on E4 risperidone in adolescents. So this is a phase 3 open label single arm study. It's a multi-center study performed in Estonia, Finland, Georgia, Latvia, Poland, and Sweden. And the treatment was estetrol, 15 milligram together with drospirenone, 3 milligram with a 24/4 day regimen, and up to 6 cycles. And follow-up was made at cycle 3 and 6. And the young girls, they reported vaginal bleeding, menstrual pain, pain medication use in this study by an electronic diary. And the results were compiled in descriptive statistics. And the primary objective of this study was to assess the safety and tolerability with this contraceptive, E4 drospirenone. And secondary objectives were to evaluate the effect of E4 drospirenone on cycle control, bleeding pattern, and dysmenorrhea symptoms. And here you can see the inclusion criteria and the exclusion criteria. So these girls, they were between 12 and 17 years. They were a good physical and mental health, and they had a BMI up to the 97th percentile. And they were requesting combined oral contraceptives either for contraceptive use or for therapeutic use. And here you can see also the exclusion criteria. They should have a regular menstrual cycle and not use injectables or implantable hormonal contraceptive before the study. And of course, any contraindication to combined oral contraceptives was not acceptable. And unexplained abnormal vaginal bleeding or history of presence of recurrent pelvic inflammatory disease. And here you can see the participants that were included in this study. There were 105 young girls, and 84.8% completed this study. The mean age was 15.2 years. And 91.4% were starters the first time they used combined oral contraceptives. And 83.8% had dysmenorrhea, very high frequency. BMI was normal, 21.2. And this slide shows adverse events. And this treatment was in general well tolerated with no safety concerns observed. And there were 54 participants who reported any adverse event, but only one participant discontinued due to an EA. And there were no serious adverse events reported. And the mean weight change, which is very important for young girls, was only 0.38 kilogram. And there were no pregnancies in this study. And here you can see the bleeding pattern, which is very important. And I suggest that you focus on this light purple curve, showing unscheduled bleeding and or spotting. And you can clearly see the decrease in these unscheduled bleeding and or spottings during the time of the study. And dysmenorrhea, you remember that dysmenorrhea was very, very frequent in this population of young girls. And already after 3 months, you can see a large decrease in dysmenorrhea. And actually those who had the highest dysmenorrhea score before treatment decreased dysmenorrhea the most, which is of course very positive. And the same goes for the use of pain medication, which also decreased from 63.9% at baseline to 31.6% after 6 cycles. So in summary, this treatment, E4 drospirenone oral contraceptive, shows no serious safety concerns and minimal weight impact. And about cycle control, the bleeding pattern was predictable, making it a practical option for both contraception and menstrual regulation. And what is very important when it comes to dysmenorrhea is significant pain release with 51% less pain medication use. So to summarize, the E4 drospirenone oral contraceptive addresses an unmet need in adolescent health care, offering a well-researched and effective contraceptive choice with a good safety profile that supports informed clinical decision making. Thank you.
Thank you, Angelica. Can you, while you're getting back, just think a little back to your experience with the participants and also since the study, because we also know that people that enroll in studies aren't always the same as the people who are using the products clinically. Can you describe a little of your experience with adolescents using the pill, not in the study or even with the study?
It was actually a new experience for me because they were so young, but it was very positive. Most of them came with their mothers. And in Sweden, we had to have informed consent from both parents. So it wasn't so easy. But the participants, they were very compliant and they had no problems to use electronic diary. And what they thought was important is that this is a natural product. Because in Sweden, and I think in many Scandinavian countries, they are very aware of the environment and the effect on the environment. So they thought that this was very, very important.
And then do we have any hemostasis data like you described, Jonathan, for adolescents specifically, or?
This will be also presented on Saturday.
Oh, this is on Saturday. Yeah, okay.
No, but I can answer your question now. Yes, we have these data, and these are totally in line with what we have observed in the adult population. So very low impact on the NAP-CSR. So going back into the model, we are already at the lower hand. So this is also very reassuring.
Good, good. And Angelica, what about bone health, or do you have any data about bone health for anybody?
I think I can respond, or you can respond.
Sure. Okay.
I really think with your data, you clearly demonstrate that an estrogen is important, at least for the bleedings and so on. But something that we have to keep in mind with adolescents is that an estrogen is needed because you need to reach your peak bone mass at the age of 25. So this is during the adolescence that you are building your bone mass, and the estrogenic environment is really, really important. So here, I really think it is very good to have an estrogen which is safe, well tolerated, and that may also have a very good impact on the bone health. And this is something that sometimes we are missing by just giving, okay, we provide a safe pop, but at the end, okay, it's safe for the risk of VTE, but regarding the bone health, I'm not sure at all. And it's important here to keep in mind that we can have a safe estrogen that may also take care of the bones.
Yeah, you're better than a gynecologist always. But, you know, I want to ask to Angelica something. We said also in my talk that the first prescription is very important for future compliance. How do you see, you know, they were happy, the family, they were happy because of the environment, etc. But how was your experience with the little girls? They were happy to go on further the study. How was the compliance on the long term in your department?
when it comes to the patient that we had, most of them wanted to participate in the study because they had dysmenorrhea and not for contraceptive use, and they experienced relief in this symptom. And I think that's very, very important. And I think it's also crucial that for a young girl that the first experience is positive. Because if you have a negative experience from the beginning with mood symptoms or bleeding problems, maybe you will not try this again. So I think that's very important.
Yeah, and this is in line with my conclusion, because in the meantime, Mitch will take care of the question that have come from you, and we will try to answer to this question. It's really important. Oh, I forgot. Where is the? Yeah, give it to me. Thank you very much. It's very important we summarize and what we have learned today. First of all, that with estradiol starters reported an improvement in mood swings or remain symptom-free, because even if you do not change, this is a positive effect, keep in mind. And this is true as well for sexual function. We learn as well that with estradiol we have a predictable bleeding partner. So we really can expect the bleeding in the majority of the case and not so much unscheduled bleeding. Very important point, safety, natural estrogen-based COC, and one of the examples is estradiol, but this is really applied to estradiol-containing pill. We have a good safety profile, and Jonathan was very provocative to say we have to change the guideline. We will see, maybe we will do it, and I hope soon. As estradiol is an effective also option, very, very good safety profile for adolescents that seek help for the bleeding, for dysmenorrhea, and they can go on maybe in the future also for contraceptive purpose. So thank you for your attention, and I hope that now we will have a beautiful question to answer.
So I'm happy for this meeting. Hope that most of you have learned some new things. Now we have some time for question and answer, and I do thank all the panelists who are joining me here now for answering the question. We received most of question concerning the risk of thrombosis. So I think that Jonathan, if he can join us, he can answer to this question better than others.
Hi, I'm here, but the problem is that I cannot switch on my camera because this is...
Yeah, me too, I cannot switch my camera. I want to say hello to everybody, Professor Nappi. And double S, Rossella, double S.
Okay, so I think I am now in. Okay, perfect. So I think we have a question related to the risk of VTE in patients with active cancer. And thank you, Mitch, for clarifying also the question. So as you have already responded, and I fully agree with you, up to now, we have no data regarding the risk of VTE in patients with active cancer. And obviously, the same limitation that applies to 18 estradiol containing pill should apply also to natural estrogen and estradiol in particular. So for the moment, there is no recommendation of using estrogenic therapies in patients with active cancer.
Thank you, Jonathan. And Yes, there is another question about the risk of thrombosis in a woman over 40 or more. But
40 or
actually,
more.
yeah.
Yeah, this is a question which is in my view. So we do not have epidemiological data for the age above 35 for E4 DRSP, especially concerning the risk of VTE. But I think in the future, and it is important to consider that E4 is also studied in patients suffering from menopausal symptoms, and it is used at the same dose and even at a higher dose than the one which is currently used in E4 in association with DRSP. So in this transition period from 35 to 50, I really think that the data that we have gathered so far, especially in the contraceptive indication, but now also in the menopausal indication, are very reassuring. So the impact on the hemostatic parameters are very, very safe with E4 alone at the dose of 15 or 20 milligram in the menopausal indication, showing less impact on the hemostatic system than 18-estradiol containing pill. And we can really believe that with E4 in the menopausal indication, we have an impact on the hemostatic system, which is similar to what we can have with estradiol given transdermally. So this is also very reassuring. And I think that in this transition period, at least the biomarker data that we have gathered so far are very reassuring as well.
Yes, thank you very much. This is really, really important to all of our patients, since we can think about having a contraceptive that we can keep on going and using it just
Exactly.
after the menopause. So this is going to be a really reassuring and nice confirmation of safety of the association of estradiol-drospirenone. We have, I think we should take out this, let's say, a misunderstanding about the fact that we can have hyperkalemia using drospirenone. I don't know if Mitchell want to answer to this question, or you, Jonathan, which or one of you.
Well, those concerns are part of the labeling because drospirenone does have antimineralocorticoid effects. In the phase 3 studies, there was one patient that exhibited very high K levels, and that was after the drug was discontinued. And keep in mind that the relative dose of drospirenone, as far as compared to spironolactone, is much, much lower. I think the concern is, just as a good clinician, if you're going to give somebody a medication that could cause potassium retention, you want to look at their other medications, their other health issues, and make sure they're not on multiple medications that can do the same thing.
Yeah.
Keep in mind that the majority of people, the vast majority of people you're going to prescribe a combined hormonal contraceptive to are not going to be in the health status that they would be on other medications that would cause potassium retention, unless you're also using spironolactone for acne treatment. And if you feel that you want to use a drospirenone product also for their acne as a combined hormonal contraceptive, it just means checking their potassium at baseline and after starting use. But those are going to be the rare patients.
If we keep on going through the questions, someone asked whether we are going to change the guidelines introducing natural estrogens over ethinyl estradiol association. To my information, since now we are not going to change guidelines, but we can give some information. There is Terhi who wants to answer to this question, maybe. You have the microphone. Yeah.
Okay, so I think maybe, can you hear me now?
Yeah, perfect.
So actually we have already done this in our Finnish guidelines. So we have pulled up the natural estrogens as the first option for combined contraceptives, due to the fact that I think we thought as a evaluation team who were building up this guideline update, is that I think there is enough of information to promote it the first line at the moment. I agree with you, Jonathan. I think it will take us time to wait for the more of the real world data, but we already had other natural estrogens available for quite some time. And at least in Finland, we have national data also on the VTE risk that shows very clearly that there is a lower risk for VTE for these products, and it looks like that the women are happy with it. And in a context of contraception, we have now put it on as a first line. There is no rigorous guiding for the doctors to really there is no force to start it first line, but we have introduced it as a first line pill in our guidelines. So we have already done that, and I know that there are other Nordic countries that are just now about to update their guideline, and we have had discussions, and I think they're also considering it.
There is also Rossella wants to give her.
Hello, I want to reinforce what Terhi was saying, meaning that, of course, we really need more real-world data, especially with the newer one, estradiol, even though surrogate markers are very reassuring. But it's true that in all those conditions, even though we cannot put as a first line, but at least in those conditions, in which maybe we are in doubt, the risk, the benefits, the eligibility criteria, etc., etc., etc. I think we should think first natural estrogen and then all the other, because we have plenty of clinical situation in which maybe a woman, she's smoking 3 cigarettes, okay, there are 5 cigarettes, there are 7 cigarettes, and we are in doubt. So I think first choice is a dream because it means producing products for women with a very, very mild impact on their body. And this is something very important for contraception, in my opinion.
I do agree with you, Rossella. And we have 2 different questions, both on the bone density. So I think that Michelle, you can answer to that, or Jonathan, which one of you wants to address?
Well, the studies to date have looked at bone markers, and both in reproductive age women and in menopausal women as part of the estetral menopause studies have shown, just to summarize it easily, just changes in the direction you would want with building bone. So there are no necessarily comparative studies. I don't think that this would be a product that would put people at risk of developing osteoporosis. Keep in mind that the product that is moving forward through regulatory approval for menopause is the same estetrol that's in estetrol, drospirenone, Drovelis. So it's not a concern for me.
No, clearly, and I confirm that for me it's also not a concern, and the bone biomarker are going into the good direction. So this is exactly what we can expect, and E4 is probably very good also for the bone. So I agree with you, Mitch, but obviously we do not have yet epidemiological data, and it's very difficult, especially in the contraceptive field, to collect these data. It's also the same for the other estrogens.
Thank you very much, both, for this good answer that can relax our colleagues who were worried about possible effect on bone density. And we also have another colleague who asked whether we do know if there is a possible effect on breast cancer risk, since they have patients who are anxious about the recent data on Dianogest. So I think that Mitchell, you can answer to this question, or Rossella as well, the one that you prefer to answer.
I'll always let Rossella go first. Rossella, you're muted.
Got the microphone. Microphone on, Rossella.
I didn't think it was possible not to hear Rossella even through
Go
the
ahead, because I had to attend one little thing and I didn't listen very well to the question. So
okay. That is a great question. I think specifically the question also mentioned that people are nervous about Dianogest. And I think one thing that should be clear is that the database studies that were just published looked at high dose progestin use in older reproductive age women who had other diagnoses. So Dianogest is associated with increased risk. Doesn't mean it's causative, but is associated in people where it's being used primarily for menstrual control and high dose, which is something that's been seen for a while with other similar products. And the data doesn't differentiate, and this is really important to keep in mind, whether it's the agent or the reason the agent is being given. And when you look at the data as a whole, when I teach on this point, it really looks like it's the reason those patients who are needing it for heavy bleeding or abnormal bleeding are more likely to be the ones who might develop cancer, not the drug itself. That being said, so when you're using Dianogest or other progestins in a combined oral contraceptive, it's being given very differently. But also very importantly is E4 has unique actions on the breast that are inhibitory and actually inhibit estradiol impact on the breast. When you look at animal models where human breast cancer cells are used, estetrol works exactly the same as tamoxifen. It doesn't mean that it's going to, we have no idea what this will mean in the long run. The phase 1 and early phase 2 studies that have been done to look at using estetrol in breast cancer treatments do show some positive results. Nothing that's overwhelming. I don't think we'll ever see estetrol as a breast cancer treatment. But the thing that intrigues me the most is, will patients who are using an estetrol containing oral contraceptive for years during their reproductive lifespan potentially have lower risk of breast cancer later in life? Based on the physiology and pathophysiology of what's going on, I see that as a high potential. I don't have any concern that it would increase the risk. And that's actually a whole other talk about how ethinyl estradiol products truly don't increase breast cancer risks with any substantial significance. But I do look at the estetrol product as possibly having some benefit. So taken as a whole, I have no concern about any combined hormonal contraceptives truly increasing breast cancer risk. They do increase the risk of being diagnosed with breast cancer, and that risk is minimal, very minimal. We're talking on the order of a few people per 10,000. But whether it actually increases the risk of developing a new breast cancer, the evidence is that none of them likely do. Estetrol has that potential to actually decrease the risk over time. And it'll be interesting 20 years from now to see what that data shows.
Yeah.
Thank you very much for having said that, because we do need to reassure all the colleagues that the risk of breast cancer, and reassure also the patients that the risk of breast cancer using combined hormonal contraceptive is not that high. Rossella, please go ahead.
Yeah, you said already. I think in this environment in which we have so much hormonophobia, and it's so important also what Mitch said in terms of selection of patient, because when we report this data like that they don't mean nothing, because we know that we prescribe Dianogest to a specific category of women. And if you think about and you look at the literature, these women, the other one, that usually they have hyperestrogenism, estrogen imbalance, estrogen hypersensitivity, lack of activity of the progestogen. So the balance, the endocrine balance of women prescribed with Dianogest by very thoughtful physician, it's completely different from the other one in which we select another progestogen. So we really need to be careful. Association is not causation, okay?
Terhi, please go ahead. You wanted to say something?
Yes. So I think I'm just going to remind the colleagues that, you know, that the women probably don't realize how they might have other bigger risk factors such as obesity or smoking or alcohol use, that, you know, I think that's a great opportunity to open that question and steer it away. I mean, like, thinking about the risk related to contraceptives is really minimal compared to the, for example, obesity or alcohol use. So I think I would encourage to look at those numbers. They are so much higher, and I think we still need to inform women that these lifestyle factors have actually a major risk on cancer, and not these preparations.
Terhi, that
This
is
really important.
so important. I'm sorry, Manuela. Actually, because the modifiable risk factors that people don't think about, and one of the other things to keep in mind whenever we look at all these large population database studies, especially the ones that come out of Europe, is they can't control for all these modifiable risk factors.
Yeah.
They don't, and they're missing the majority of the data on those modifiable risk factors. So I would stand in line right behind Terhi and say that 100 times. It's a great point, great thing to remember.
Thank you very much, because this is really important to be said. We have some factors that we can modify and reduce risk, and usually women do not like to be addressed by saying, well, it's better that you stop smoking instead of stop taking the pill, which is really important to be said. And we have another question about the impact on CIP for 50 and the use of anti-epileptic drugs. Probably the answer has already done. And if we have new data on the fact that estradiol and estradiol or natural estrogen are better than the association with ethinyl estradiol all over, meaning that it's not just for the VTE risk or other things. It's not. It's just generally. Do we should consider them better? Yeah, Terhi.
No, just waving to Rossella to
Okay,
I think she's leaving. I'm sorry, your question was about, was it still about
about the fact that we should consider this association with natural estrogen or estradiol better than the association with ethinyl estradiol?
Keep in mind that you still have drospirenone, which is metabolized by CYP3A4. So you will still have some interaction due to the presence of drospirenone. But E4, it's true that it's not metabolized by CYP3A4. So the association may still have some interactions, especially with strong inducers or inhibitors of CYP3A4. So this is something that you have to keep in mind. But regarding the estrogenic component with E4, we do not have such kind of interactions.
Thank you very much. I think we have just the time for the last question, then we will say goodbye to each other. And it's about the use of the estradiol in breastfeeding women or partial breastfeeding or not breastfeeding. I think that the guidelines that we have on use of estrogen in breastfeeding women are already enough. The ESC already sent out the new guidelines for some statements that we decided as the European Society of Contraception, and we are going to publish them on the journal. They are going to be ready in a few days, should be. Yes, Terhi, please.
Yeah, just thank you. To a good reminder again that, it's not that we don't prescribe, these preparations because they would harm the child, but, it's just the fact that they will cause a little bit of an extra risk, especially the EE preparations for the VTE after you've given birth. So that's why it's the 3 months. It's not because we're thinking that they would harm the child or that the milk would be kind of a spoiled for the child. So that's just for the VTE risk cases. Yeah.
Thank you very much, every one of you. It was really a pleasure to have you all here for this discussion, and I hope we can have another good webinar all together. Many, many thanks. Have all a nice evening.
Thank you.
Thank you very much. See you soon, and take care. Bye-bye.
Bye-bye.
Bye.